Hi, my name's Dr. Amir Khan and I'm a GP at the Ridge Medical Practice in Bradford. If you're thinking about a career in general practice and want an idea of what you're letting yourself in for, then our peer-to-peer sessions offer a bit of insight. Each episode features genuine conversations between GPs and other practice colleagues.
I'm Eunice, actually. I'm a physician associate. I qualified in 2010. Out of those last 11 years, I have spent nearly 9 now in general practice. I've been in this one for 8 of those years. I also am a joint clinical director for the local PCN and I also work for the CCG around workforce.
So hello, hi. My name is Elvis Martinez. I'm a GP. I have been a GP for about 12, 13 years. I am originally from Colombia in South America, and I qualified as a doctor there. Came to the UK about 20 years ago. Went through all the exams that an international doctor has to go through to become a doctor in the UK, and successfully did that. And completed my GP training in 2010. So I've been working in this practice for about 5 years and became a partner 3 years ago. I have a special interest in ophthalmology and end-of-life care, and I am currently the senior partner at this practice. So I worked as a salaried GP in a practice where I trained for about 7 years, and even though it was a training practice, I never had experience working with physician associates. So when I moved to this practice, I met lovely Eunice, who I really didn't know who she was, what she was doing here, and very quickly I learned the potential, because we had meetings every day to discuss patients and have clinical discussions and projects and all that, and I just couldn't understand when I asked her who was this doctor, and they were saying like, no, she's not a doctor, she's a physician associate. And as they say, what's that, physician associate? So obviously I start to have conversations with Eunice and very interested about her training, and I was really, really impressed to see the wide variety of expertise that they can use within general practice. So Eunice is definitely an essential member of our team, and she has gained so much respect amongst the team and all the staff, because she's just so useful. She's very good with patients, so she will just work along all the clinicians in terms of doing clinics, seeing urgent patients, chronic diseases, helping out with QOF targets and all the targets that we GPs have to achieve during the year. She participates a lot in practice development, new projects. She's always very keen in just having something to contribute towards the practice development.
And I guess that for me kind of helps to illustrate I guess like how PAs work as part of the team and very much become integrated amongst it, and hopefully, as you've just said, quite helpful, and that I think especially being a PA, when you tend to generally work as part of an MDT because we tend to be a bit of a minority, but actually you're not necessarily seen as being particularly different, and that your views are respected and your skills are respected, and very much, as we sometimes describe it, as like a physician extender, that we kind of just support in all the same ways that sort of the other team members do.
So I have no doubt that using or employing physician associates to work PAs in general practice I just feel that everyone should do it. Everyone should have a physician associated part of their team. And I think something I like about working in general practice is that obviously we're all generalists, but we all have some kind of interest for certain areas. And one thing I like about you is that you tend to have to attract all these patients who like to want more time to talk about things, because is Eunice there, or where is Eunice? They're always asking for Eunice. And the fact that they actually call you Eunice, I like that. I like that they, because they usually say, oh, I saw this doctor, whatever. They don't remember the name, they don't remember who they were, they don't even remember. Or they could tell me, no, I saw you. And I said, but I'm not Dr. D, Dr. Lewis, I'm not. Say, okay, whatever. But when they see you, they remember Eunice. They remember it's the girl who was actually took the time to listen to me, to my problems. And I keep saying to you, don't be too nice, because you're going to be there forever just listening to the patient. But actually, it's a very good thing. It's a really good thing, because, patients went from historically, they always prefer to see a nurse because the nurse, has more time to see the patients and, things like that. And they know the GPs are really busy. And it's interesting how the things that we have this discussion about these things that patients disclose to you because you've been so attentive to listen to them. And I like that. I like to have someone who at least, they feel that they can come to see someone in my practice where they feel free to talk. And I know that they don't feel free talking to me, but I just feel that that's great.
Yeah, that's good. I'm glad. I guess I don't always hear that, because they don't come back to me and say exactly the same or in that way. But that's really useful to know. I think I like talking to people. That's kind of why I do this, or part of the reason I do this, and building up those relationships. And I think in terms of healthcare continuity is really important. So actually, if you can build them, I do think you help people. They're more likely to tell you when something's wrong, and it makes it easier to pick things up that way. So that's really good. Whenever I go and give a talk about PAs in primary care, it's one of the first questions is, but they can't sign prescriptions, so what do we do? And actually, I guess, once again, COVID's helped a little bit with this, but it's just never been as big a problem, I think, once you're working with it. So pre-COVID, I would knock on the door, and there's always one person at least, usually the duty doctor, who has a bit of an open door policy, knock, sign, and we're done. I have worked in a practice where they had a box at the front of the surgery, so whenever their system was a little bit different, because they didn't have like an electronic calling system, so they would have to go out and call their patient, and when they did that, they'll sign everything in the box and then continue. But now we do electronic prescribing. It's so much easier. So often it'll be like a screen message saying, can you sign this off, please? And each opportunity, whichever way we've done it, has allowed the clinician to ask any questions, should there be any, either way. So whether I've got one about the prescription, or whether they're questioning why I may have chosen one thing or over another. Guidelines are always changing. So yeah, it's not actually as big an issue as I think people maybe create it to be before having a PA. What do you reckon, Elvis?
Yeah, no, I agree with that. It's definitely not an issue at all. As you said, before you came, you knocked the door, and then obviously we have any queries, we will just ask straight away. But obviously, as you build up this rapport and trust, and then we know what question to ask, which usually, most of the times are fine. And now, similar, as you said, send the prescription into the online inbox, and then you send a message saying, can you just sign this because it's urgent, and then we ask the questions if we need to, but generally it's not a problem.
No, there are little bits, I guess, of difference. I guess, we talk about prescriptions and stuff, that definitely falls more on your lap than it does mine, and being a PA, not being able to prescribe at the moment. But sort of day-to-day sort of appointments, like routine stuff, urgent stuff, I guess we both share. We were talking the other day about, I used to do home visits. I used to do a lot of the routine home visits, because that's just the way sort of our practice sort of designed things. But then I think we've done joint home clinics, where we kind of went to the local residential care home and worked together. I think we spent a day there trying to make sure we've seen everybody and sort of discussing them as we went along. And I think that was quite nice. That was an opportunity where actually we worked quite directly together in a very team-like way. What other things how would you say our roles differ?
Well, I quite like having you around because you sort of keep the balance between the GPs and the rest of the team. And I think is it is important when you get to do so much work, like, general practice, like in hospital, I guess it gets very hectic and things like that. And then you tend to do just the one thing, one thing, one thing, one thing. And then when you get someone like yourself, you obviously you are open to help everyone in different aspects. And as in you said, you help with the chronic condition, you help with the home visits, you help with the daily triage, telephone triage, and things like that. And then because we don't have to supervise you all, but you are always under us. We always tend to, okay, we need to behave better because you need to, show and promote, because, we want you to improve doing your job. And the more that we help you and you engage with us, then obviously the better use we get from someone like yourself with all your skills and things like that. So I really like that. And also we rely on you, and I'm sure it's something that physician associates can do across the all different jobs is to help us with all the projects. I mean, you obviously like to get involved in projects, and you always um, doing a bit of IT and helping us with the audits, and then pushing people to complete tasks and targets and things like that. So I think yeah, well, I'll be here all day talking about how a physician associate could improve or help working in a GP surgery. But
That reminds me, actually, we work with the PPG together. That's the non-clinical that we do. We like the website and stuff. I guess I think I quite like going beyond, I guess, the clinical stuff, and I get quite involved in quite a bit. Working and with the other teams as well. So cross team meetings, I think we've both been to.
And what I
Sorry.
wanted to say, what I wanted to say about the PPG is another thing that I've noticed since I started leading the PPG. PPG is a patient participation group, people should know. And so in general practice, we have to have representatives from patients, and then we do meetings regularly just to improve services and feedbacks and all that. And I've been doing this for a few years, doctor with a nurse or with someone admin. But since you joined the group, attending the patient participation group, they feel I don't know. I think they feel more comfortable that someone there who I don't know what the perception of who you are. The doctor, the nurse, so you're someone different that could be perhaps closer to them, and then that's why they start again telling you everything, which in a way is good. Which in a way is good, but that helps us because sometimes they feel our doctors are too untouchable, and they don't want to tell us things because they think we're going to reject that or say no. But it's good again. I'm probably in love with you, but anyway. I like when patients say to me, when I'm trying to book you with a patient, so we do the telephone trials, and I'm trying to book an appointment with you, and they say, because you keep saying, no, you must tell the patient who I am because I don't want any surprises. I don't want them to say, oh no, when I introduce myself, I don't want them to be disappointed because I'm not a doctor, and sometimes they tell me, so I will tell the patients, well, you're going to see, well, a physician associate, and then what is that? Hi, she's just someone really nice. Just come and see her and talk to her because she's really nice. Sometimes it's quite difficult, and I don't know. Maybe we need to do something to promote more your role, because people know you, but people got to know Eunice, and they, I guess some people don't care who they see, as long as they get the help they need. But I think that's one of the things that sometimes is quite difficult to say. Okay, who is Eunice? But Eunice is a physician. It's not a doctor. It's not a nurse. It's something in between. But you definitely will get help. I promise you. Um, Well, I have, as you know, we do the telephone triage and trying to allocate patients to clinicians. And I have patients choosing you over a doctor. Simple as that. Because they know you, because they trust you, because, they know that you're going to sort out the problem. So, yeah, I don't have particular problems with that. So you arranged for me to do these home visits, and with this elderly patient who she has dementia, and so I went to see the patient, and when I arrived there, so I said, well, this is the doctor, and then she was, oh, I spoke to Eunice, and said, no, she's no, no, it's me who's doing this, and I said, well, I don't know. I don't remember where is this for, but while you're here, why don't you fix my boiler, because it's not working? So I thought, okay, so she felt really comfortable speaking to Eunice, and Eunice dealing with the problems, but she thought that the doctor probably was more helpful fixing the boiler. The one thing I like about working in general practice is that obviously we chose this because we like the work life balance is definitely much better than doing long hours and in hospitals. Not that we don't do long hours here, but they are more bearable, and so we don't hold blips. We don't have people just standing there for you to run and things like that. And yeah, so that was one of the reasons why I chose general practice. Um, and when I started doing general practice, I was like, oh my God, I'm going to be all day just dealing with all these chronic problems and things like that. But I didn't realize the vast thing, all the things that you can actually just branch out into doing.
And in terms of my branching out, I guess I ended up going more towards sort of like in sort of like leadershipy type stuff. I've got a real quite interest in workforce, both clinical and non-clinical, because once again, I think it kind of leads on to the patient experience. So that's why I'm involved with like the PPG and the PCN level patient engagement, because I just think it's really important to maintain those connections. I think the role of general practice is changing sort of like over time. So I did like a Darcy fellowship last year. And I think once again, I helped run the educational series within this practice, which I've kind of just made everyone get involved with. Myself and one of the other clinicians literally pulled names out of a hat and told people to present something once a month. And once again, just sort of like encouraging people to bring their skills and their knowledge to the forefront. And once again, it just creates another opportunity for us to kind of get together and have a chat. It's not meant to be intense, and I think they've been quite useful as well.
One of the things that happens when you tend to do this job for some time is that although we have this wide variety of things, one day you can have, I don't know, a heart attack walking into the room, or you can have someone who's about to deliver a baby, or you can have, a child with problems, you name it. So every day, and that is exciting. For me, it's exciting. I wouldn't be able to do the same thing every day, 10 minutes after 10 minutes. So I find that fascinating. But you sometimes get to the point where you think, oh my God, is that what I am? Just a generalist? What do I do? I know nothing. I have to go and do something else. And but when I'm in hospital, right, and I am the GP with a special interest in ophthalmology, and then you get ophthalmologists that know nothing about, apart from the eye, which the eye is just a small part of your body, imagine. And then you see all the crazy things that they said about the rest of the body. I was like, what are you talking about? You don't know anything. And then that's when I feel, I bloody know a lot. I know a lot of things. And they have a lot of respect for me. They just come and say, oh, everyone comes to ask me question. If someone collapses in the eye unit, the first one who needs to go is me, because I'm the one who knows about, heart attacks and strokes and all that. So it actually just doing different things and having a different interest in within medicine, it will make you realize how good GPs are, how much we know, how much information we hold. I don't think any clinician in hospital will know the range of pathways and two-week rule referrals criteria and medicines optimization, protocols and all that. So I think it's an amazing position to be in.
I was thinking before about the things that we've done in terms of developing relationships and building on things outside of the practice, not just thinking about. Once again, you can probably tell that I've got this thing about like team building and workforce, and so we did like Tough Mudder a few years ago. A group of us did that, raised some money for charity, and then we did Gung Ho. I think a couple of years later. Always ready to have like a Christmas jumper competition and
Yeah,
and that kind of
I
thing.
still remember pushing you over that thing that we have to just come across that big barrier that we have to push some of us into that thing. But it was great. It was great fun.
What we've been talking about, like on a PCN level, though, is what's been quite nice is obviously practices work very individually, but what PCNs kind of encourage people to do is know the practice next door a little bit better. It's like, actually, you've been down the road all this time, and I've never really come in and sort of had a look, and now it's more likely you're going to have a meeting with them, for example. And then we've got like the protected learning time events that happen sort of like once or twice a year, and I know that the one this year that they're thinking about it being on well-being, especially with everything that's happened over the last year, they thought that might be quite useful. So then we do smaller stuff, but actually also larger stuff, which is quite nice. It is good to network with your neighbouring practices. Once again, there's so much that can be gained from having those relationships, sharing resources and information and knowledge, because often it's probably loads of duplication that's going on, but actually if you foster those relationships, that can really help, and I think we're on a good path to achieving that. Yeah, I think that's a definite perception of primary care is that you work in silos and that's it. You do shut the door and you won't see anybody else all day. Got to say, COVID did kind of start leaning us that way a little bit. Although we had teams and that kept us connected, but it's not all like that. There is an element of it. The reality is, you do have a room and you do shut the door and you see individuals, but there's a lot more that goes on around that, which involves speaking to people on your team, getting to know your team on a daily basis. And I do think it's a lot more interesting in that way than people think it is.
Well, I will say that this is one of the good things about working in general practice, that we are constantly reviewing our practice outcomes and things like that, and then where we see the need, then we try to build up or take it from there, and then try to build up a service that can actually help people, prevent people going into hospitals or having further problems from their chronic conditions. So our PCN clinical directors are always willing to hear um, from ideas and projects that we can set up, and they will take it into account and then discuss it within them and then take it further to make changes. So I would say that generally we have different changes, engaging into CCG schemes and things like that. Is is something that it could be done.
I think that the challenge remains throughout the NHS in terms of there being quite a heavy top-down approach. We get our QOF targets, what it is that we're meant to be doing from the top. But what's nice about general practice is it's a smaller area to make quick changes and trial things quite quickly. So if somebody does identify an issue, you can get a message across the team quite quickly. We meet on a regular basis. We meet weekly as a clinical team and monthly as a cross team meetings, but it allows everyone to bring their issues from different aspects of the practice and make really quick change. Or even when we have directives that come from like NHS England or the CCG, we can then try and think about how we can incorporate it to match our practice population. It's a bit like, all right, so we need to meet this target, but how do we do this to benefit our patients the most and or in the best way. And I think working in a practice does allow us to do that.
So thank you so much for listening or speaking to us. I am very happy to be a GP. I recommend anyone who is interested to just come along and get the experience, get the feeling of what general practice is. It's a great specialty to be in. It's amazing to be able to work with all this group of colleagues within the community. Having PAs is a great addition to the practice, whoever is thinking about employing a PA. And I'm sure I said enough, but if you have any questions, just give me a call and I can tell you more about this.
Yeah, I think it's really exciting because I think it's what patients want in terms of being able to access a range of skills and things in sort of like the community rather than always having to go to hospital. And actually, if you can upskill people, then it does mean that not everyone does have to go into a hospital setting, which can be quite stressful. Yeah, I think this is a really exciting time for primary care, actually.
So thank you so much, and then I hope if you go ahead with your application for GP, I will be waiting and very happy for anyone to join the general practice.